Welcome to the Depth Dive. This is where we take dense clinical standards, complex research, and really distill it down into knowledge you can actually use.
Right.
Today, our mission is, well, it's critical. We're doing a deep dive into the latest guidelines on acute coronary syndrome, ACS.
Exactly. And we're really honing in on the practical, high-stakes takeaways for primary care. ACS covers both acute myocardial infarction, AMI, what most people think of as a heart attack, and unstable angina pectoris, IAP.
And our source.
We're leaning heavily on a major European guideline, the NHG-Standaard. It's often seen as a benchmark, especially for acute triage.
Okay, so what the experts say you really need to know when someone presents with those worrying symptoms. Let's start simple. What exactly is ACS?
At its core, ACS just means you've got symptoms developing acutely right now that strongly suggest myocardial ischemia. The heart muscle isn't getting enough blood. Simple as that.
And that lack of blood flow, that's the key to the symptoms, I assume.
Precisely. So let's start with the picture everyone knows. That crushing retrosternal pain, maybe tearing or like a band tightening around the chest. The guidelines do confirm, yeah, that's the main symptom for many.
Right, the textbook case. And then you have the common co-stars, shortness of breath, so dyspnea, sweating, maybe nausea, pain shooting down the left arm or shoulder. That's the classic picture.
That's the script.
But then reality throws a wrench in the works, doesn't it? Especially with age.
Oh, absolutely. And this is where we really need to shift our thinking. The data is clear. The single biggest factor driving how symptoms present is age. Much more influential than sex differences.
That's interesting because, you hear so much public health messaging about how women present differently. If age is the bigger deal, why the focus on sex?
It's a fair question. I mean, the differences between men and women are there. Statistically, women might report more pain between the shoulder blades, more nausea, jaw pain, things like that. But when you're in the acute setting, making that immediate call, those differences often pale in comparison to the huge change that happens once a patient is over, say, 65. And another layer is how symptoms are interpreted. Women might unfortunately be less likely to think heart, even with identical symptoms, which can delay seeking help.
So let's take that older patient, maybe 70, 75. If they don't have that classic chest pain, what are they likely to complain about?
Often it's much more vague, nonspecific. Sometimes it's just profound weakness, sudden fatigue, or maybe primarily shortness of breath.
Dyspnea again.
Yeah, dyspnea might be the main thing. Chest pain could be minor or even completely absent. And we have some really stark data here.
Okay.
If you look at patients aged 75 to 84 with a confirmed heart attack, an AMI, roughly half of them did not report chest pain as a primary symptom.
50%. Wow.
Half.
Yeah.
Compare that to under 45s, where maybe 85%, 87% have that classic pain.
That changes everything for triaging older adults.
It has to. If you're seeing an older patient, the absence of severe chest pain tells you almost nothing about ruling out ACS. You just can't rely on it.
I can just picture primary care docs listening, thinking back. Was that fatigue? Was that reflux? That single statistic really recalibrates your internal alert system.
It should. Vigilance based on age is absolutely critical.
Okay, let's shift gears slightly. From symptoms to the cause, the typical idea of a heart attack is a blocked artery. But first, give us the overview, the good news.
Well, the good news is genuinely fantastic. Thanks to decades of effort, less smoking, major improvements in diet like cutting trans fats, AMI mortality has really plummeted.
How much are we talking?
For patients 45 and older, the 30-day mortality rate fell from around 17% back in 2000 to just 4% by 2016. That's incredible progress.
That really is phenomenal. Okay, so back to the mechanism. Is it still mostly that blocked pipe scenario?
Yes, the vast majority, over 90%, is what we call type IMI. That's where an atherosclerotic plaque ruptures, a thrombus forms right on it, and boom, blood flow stops or slows dramatically.
The standard picture.
Right, but we're increasingly recognizing cases where there isn't a major blockage like that.
So the patient has heart damage markers in their blood, but when you look at the coronary arteries with an angiogram, the main vessels look.
Okay, exactly. That brings us to the non-obstructive causes. Firstly, there's myocardial infarction with non-obstructive coronary arteries.
Minorities.
Accounts for maybe 6% of all MIs. You've got proof of heart muscle damage, but no significant blockages in the major arteries. These patients tend to be younger, and it's seen more often in women.
So if the big pipes are clear, what's actually causing the heart damage?
It could be a few things, maybe disease in the very small vessels, coronary artery spasm where the vessel clamps down temporarily, or sometimes it's something else entirely, like inflammation, myocarditis, mistaken for an MI.
Okay.
And there's another specific one, rare but important to know, SCAD, spontaneous coronary artery dissection.
C-section, like a tear.
Exactly. The layers of the artery wall just spontaneously tear apart. It's not plaque rupture.
And does SCAD affect a specific group?
Overwhelmingly women, about 90% of cases, usually around age 50, often without the typical risk factors. Recognizing minoca and SCAD is crucial because treatment might be different than for standard plaque blockages.
It really highlights that ACS is a broader category than just one disease process. Okay, before diagnostics, touch on other risk factors that impact how people do.
Sure. Beyond the usual suspects, age, smoking, diabetes, high blood pressure, cholesterol loss, the guidelines point out the big role of social factors.
Right.
Well, ethnic minorities often face a tougher prognosis after admission. This is frequently tied to having more of those traditional risk factors or having them develop at a younger age. Cultural factors can play a role too.
And psychosocial factors, you mentioned those.
Yeah, things like low socioeconomic status, chronic stress from work or family, social isolation. These are strongly linked to worse outcomes, more readmissions too.
Why is that?
It often boils down to compliance. It's harder to stick with lifestyle changes, take medications regularly, attend rehab if you're dealing with significant life stressors or lack support. The best medical plan only works if the patient can actually follow it.
That really underscores the need to see the whole person, not just the EKG. Right, let's move into the thick of it. The diagnostic challenge in primary care, right there in the acute moment. If time is muscle, what tools can we rely on?
This is fascinating, actually. What the standards specifically warn against relying on in those first crucial hours. Take the ECG, the electrocardiogram. It's essential. Yes, you need it to tell a STEMI, the really bad one with a total blockage, from an NSTEMI or unstable angina.
Okay.
But crucially, an ECG is not reliable for ruling out ACS in the acute phase.
Wait, why not? I thought a normal ECG was reassuring.
In the first few hours, it has a low negative predictive value. You could have serious trouble brewing, a plaque about to rupture, and the ECG might still look perfectly normal. It tells you more about the current state of blockage, not necessarily the underlying unstable process.
So, necessary, but not enough to say you're clear. Got it. What about those rapid blood tests? Point-of-care tests, POCTs, for things like troponin, they seem so convenient.
And the guidelines are pretty firm here. They're not recommended for this purpose in primary care.
Really? Why not?
They just don't have the required diagnostic accuracy, specifically the sensitivity, to safely rule out ACS early on. You get too many false negatives.
False negatives meaning the test says no problem when there actually is one.
Exactly. Studies show false negative rates anywhere from 4% up to maybe 14% with some of these rapid tests in the early phase. Relying on a negative POCT result in the first few hours could give false reassurance with potentially catastrophic consequences.
Wow. So the quick fixes aren't the answer here.
Clinical judgment remains paramount. You cannot replace a thorough assessment and high index of suspicion with a quick test in this scenario.
So if the quick test and the early ECG aren't reliable for ruling things out, how do clinicians make that critical call? Are there scoring systems that help?
There are predictive rules, like Marburg heart score. They exist. They're relatively simple. But interestingly, the guidelines generally say don't rely on these scores over your own clinical assessment.
So back to clinical judgment.
Pretty much. Instead, the focus is on identifying specific symptoms or signs that significantly shift the probability. We use something called the likelihood ratio, LR.
Okay, give me an example. What really bumps up the odds it's ACS?
A big one is pain radiating to both arms. That carries an LR of about 2.6. So seeing that makes ACS over 2.5 times more likely than it was before you knew that symptom.
That's quite specific.
Another strong indicator. If the patient says the pain feels very similar to a previous heart issue or angina they've had, that's an LR of 2.2. The patient's own history is powerful.
Makes sense. And what finding really argues against it being ACS, something that lowers the probability?
Pain that you can reproduce by pressing on the chest wall. Palpation tenderness. That has an LR of about 0.28. So if you can make the pain worse by pushing on their ribs or muscles, it makes an acute cardiac cause much less likely. Still not impossible, but much less likely.
Okay, so let's say suspicion is high, based on the overall picture, the history, maybe some of those high LR symptoms. What's the absolute immediate next step?
No hesitation. Call an ambulance A1 indication, highest urgency. Get them moving towards definitive care.
And while waiting.
There are key things to do if possible. Nitroglycerin spray or tablet under the tongue, but only if their systolic blood pressure is over 90. And crucially, they haven't taken any PDE5 inhibitors like Viagra or Cialis recently.
Right, that's a dangerous combo.
Very. Then, if pain is severe, strong pain relief like fentanyl or morphine. And perhaps most importantly, give them a loading dose of aspirin to chew and swallow, usually 150 to 300 milligrams.
Okay, let's fast forward. The patient gets through the acute phase, gets treatment. What about the long game, life after ACS? What's the typical long-term maintenance?
It's usually lifelong medication. Daily aspirin is standard. Then typically another antiplatelet drug, a P2Y12 inhibitor, for at least a year, sometimes longer, to prevent clots.
Right.
Plus, definitely aggressive cholesterol-lowering drugs, usually statins, and often beta blockers and ACE inhibitors, especially if the heart muscle was damaged, leading to heart failure or reduced pumping function.
And it's not just about pills, is it? What about rehabilitation?
Oh, absolutely vital. Cardiac rehabilitation programs are incredibly effective. They reduce the risk of dying, reduce hospital readmissions. They cover exercise, education, psychological support. Really crucial.
But uptake isn't always great, right?
Frustratingly low, often. Globally, participation can be as low as 15–30% in some studies. That's a huge missed opportunity, given the proven benefits. We really need to push for better access and uptake.
Definitely. Okay, wrapping up with some practical advice for patients and families post-ACS. What about resuming, say, normal activities like sexual activity?
Generally, if the recovery has been uncomplicated, it's safe. The guidelines often compare the exertion level to, say, walking up 1 or 2 flights of stairs or doing some vigorous gardening. If they can do that without symptoms, sexual activity is usually fine.
Good to know. And that critical medication warning again, the one that can't be stressed enough.
The absolute no-no. Combining daily nitrates, common for angina, with those PDE5 inhibitors used for erectile dysfunction, sildenafil, tadalafil, etc. It can cause a sudden, severe, potentially fatal drop in blood pressure. Patients must be warned explicitly.
Crystal clear. And the overall long-term outlook.
Anyone with a history of ACS is automatically in the very high-risk category for future cardiovascular events. That means lifelong vigilance, regular checkups at least annually, managing all those risk factors aggressively.
This has been really illuminating, some huge takeaways. The sheer frequency of nonspecific symptoms in older adults, the reality of non-obstructive MIs like MINOCA and SCAD, and maybe the most actionable point for primary care. The danger of relying too heavily on early ECGs or point-of-care tests to rule out ACS.
It really comes down to clinical vigilance.
Absolutely.
And, speaking of vigilance, there's a fascinating temporal pattern. The guidelines and supporting data note that ACS events are statistically most likely to occur between 6 a.m. and noon. That's the body's circadian rhythm peak for these things.
All right, the morning surge.
But here's the twist for out-of-hours care. A patient calling between midnight and 9 a.m. is actually twice as likely to be having a true ACS compared to calls at other times.
Twice as likely in those wee hours.
Yes. So the provocative thought is, given we know about this circadian risk, and we know calls during these specific overnight early morning hours carry double the ACS probability, often when staffing might be lighter, how do we better prepare everyone? Patients to recognize symptoms then, and responders to maintain that high index of suspicion during that critical window.
A really vital question. How do we optimize our systems for that known peak risk period? Lots to think about. You've been listening to The Deep Dive, hopefully now better equipped with some perhaps surprising high-value insights from just one clinical standard. We'll catch you on the next Deep Dive.